Hello, welcome to this PrepRARE session all about the vestibular system. I'd like to turn things over for a welcome from the Vestibular Disorders Association from Cynthia Ryan, who's the executive director. Cynthia, the floor is yours.
Thanks, Celeste. Well, hi, everyone, and I'm so glad you joined us today to learn all about the vestibular system. As Celeste said, I'm Cynthia Ryan. I'm the executive director of the Vestibular Disorders Association, otherwise known as VIDA. And the National Ataxia Foundation, we are a nonprofit organization that advocates for patients, in our case, for people with vestibular inner ear and brain balance disorders that can cause dizziness, imbalance, vertigo, brain fog, tinnitus, hearing loss, and a whole host of other symptoms. And as all of you have probably experienced in your own journey, your own healthcare journey, so many vestibular patients face a long diagnostic and treatment process. So many of them they're very difficult disorders to diagnose, especially by primary care providers, and it can be a difficult road to find specialists. They may be told that it's all in their head. They're just going to have to live with it, or there's nothing that they can do about it. And when they finally find VIDA or other resources where they can learn about their condition, they can become their own health advocates. When you have information, you know how to communicate with your healthcare professionals, you get on the road to recovery more quickly. In addition to providing patient education, as well as referrals to qualified vestibular healthcare specialists, we have support networks. And that is so important to helping people feel not so alone in their journey. I can't tell you how many people I've spoken with who said, until I got connected with VIDA and their support groups, I felt like I was going crazy. I felt like I was the only person in the world that this was happening to. And now I have not only a support network, but I have, I have friends, I have family. This is we're building a community, a family of people to support you on this journey. So I hope that if any of you out there are you think you might be suffering from a vestibular disorder, today you're going to learn more about that, as well as where you can go to get information and support. So thank you, Celeste, and the National Ataxia Foundation for inviting us to speak.
Well, thank you so much, Cynthia. It's our pleasure to partner with Vita on this webinar. And hi, folks, on behalf of the National Ataxia Foundation, it's my pleasure to welcome you as well. My name is Dr. Celeste Soort. I'm the Patient Engagement Director. If you are from Vita's neck of the woods and meeting us for the first time, we are based in the United States and we support folks with all forms of ataxia, including vestibular ataxia. We have support groups, we have patient education on different types of ataxia specifically. We also provide clinician education in terms of trying to train physicians to better recognize the symptoms of ataxia, refer out, and provide treatment, supportive treatment as well. But that's a little bit of us. We also host these educational webinar series, and it is our privilege to be this connector and bring folks in and find more information. And with that, it is my privilege to introduce our speaker today, Dr. Kristen Steenerson. She is a medical doctor and a board-certified neurologist with fellowship training in vestibular neurology. She graduated cum laude from Claremont McKenna College and received her medical degree from the University of Utah, completed neurology residency at the Mayo Clinic Arizona, and fellowship at Barrow Neurological Institute. She directs the Vestibular Balance Disorders Program at the Stanford Balance Center. She has joint appointments in the Department of Otolaryngology, Head and Neck Surgery, and Neurology and Neurological Sciences at Stanford. Her clinical interests include vestibular migraine, BPPV, Ménière's disease, and international neurology. Dr. Steenerson, thank you so much for joining us today. The floor is yours.
Thank you so much. I'm really grateful for this opportunity to speak to you all. And in terms of my own interests, I love all vestibular disorders, but I'm really interested in their interaction with neurological disorders in particular. So I feel really grateful to have the opportunity to discuss this with all of you. So today we're going to talk about the vestibular system in general. So we'll go over the anatomy, the physiology, the pathophysiology. We'll talk about some common disorders that are resultant from vestibular problems, vestibular testing, and then management options. So first, let's talk about the anatomy of the vestibular system. So many think many people think of the vestibular system as an ear problem, and that's partially correct. So if we think about the ear, we actually have three ear compartments to consider. We have the external ear, that is the kind of classic ear that you see on the outside of your head. You have the middle ear, which is bordered by our eardrum and our ear bones. And then we have what's known as the inner ear. And the inner ear has two sensory organs. It has our hearing organ, known as the cochlea, and it has our vestibular balance organ, known as the vestibule. These two organs gather their special sense information, so sound information and motion information, and then send that information through this nerve to the brainstem. So the vestibular system actually has two components to it. We have this inner ear portion where we have special organs that detect motion, and then we have the brain portion that helps to process that information. So let's dive into those components with a little more detail. So for that inner ear anatomy, we can take that organ and we can look at the individual components within it. So we have five separate organs within each inner ear, so 10 organs total that help to gather different types of motion information. So those three loop-looking structures that we see are known as the semicircular canals. And then you see these spaces here are known as the utricle and the saccule. And we can think about them based on what they detect. So the semicircular canals are our rotation detectors. So angular acceleration, for example, can be detected in three different planes. So this schematic here is to show us how they are orthogonally or at 90-degree angles arranged together to help us be able to detect the most common head direction changes. So we have a horizontal canal, so that detects head rotation side to side. We have a superior canal, which detects forward motion, and then a posterior canal, which detects backward motion. And we have these paired on each side. So right and left inner ears have these three organs to help us detect rotation in all three directions on both sides. Those rotation detectors work because we have fluid inside these canals that when we turn our head, the fluid shifts and it causes these little bundles of cells to deflect. So you can see this blown up here. These are hair cells. Maybe you've heard of hair cells before, that when they bend, send nerve transmissions through these nerve endings that help to propagate signals of which direction our head is rotating, side to side, backwards, forwards. And that information from the deflection can then be transmitted in the brain to help us understand that directionality. From the angular accelerometers, we then move to our gravity detectors, which is our linear accelerometer. The gravity detectors are those two spaces that we pointed to earlier, known as the utricle and the saccule. And these are gelatinous organs that have little embedded cells in them that have the same hair cell anatomy, that when we shift our head side to side or up and down, will deflect, very similar to those other hair cells, and send nerve transmission signals, letting us know that we're moving left, right, up, down. So these help us to understand more of a linear direction or usually a gravity change, since we're always thinking about our position in space in terms of what gravity is pulling on our ears and our heads and our joints. So this might be a familiar component of the inner ear to you if you've ever heard of crystals out of place or BPPV. So these crystal organs, the utricle and the saccule, have little gelatinous components to them that have the crystals embedded on top. So I like to think of a Jello mold, for example. Or if you think of a Jello mold that has pieces of fruit suspended in it, when we shake that Jello mold, those fruit should move, and that lets us know which way that Jello mold is moving. It's very similar in our utricle, where these crystals have some weight to them, so they can help pull that gravity sensor side to side, which helps us know more discreetly which way our head is moving. But these crystals can sometimes fall out of place, and we'll talk about the consequence of that in a little bit. But this is how it's supposed to work normally. So everyone has crystals in their head. That is normal. That's not some mean thing that you hear on the playground. This is supposed to be there. It's how we functionally detect gravity changes. So with those inner ear sensors, we have our linear and our angular accelerometers. That information is transmitted through the nerve to now what we call our central anatomy, or we'll call it brain anatomy. And what that means is that there are different processing centers within our brain that help to take that motion information, interpret it, and then combine it with our other senses. So, an important and critical part of this is at the very brainstem level, where we have this area called the vestibular nucleus that takes that information and starts to separate that information out into some main mechanisms. And that we'll talk about in a second. But what I really want to highlight here is how the cerebellum is a critical part of vestibular processing of information. So there is a component of the cerebellum known as the vestibulocerebellum, which is the middle part of the cerebellum, that helps to prune and perfectly make precise the vestibular signaling and information in order to use it in these other vestibular manners, such as vision control, balance control, and orientation. So the cerebellum is critical and one of the most important parts of pruning this vestibular information, which is why it's so relevant to many people who are dealing with cerebellar problems. So let's talk about some of those functions so that we can see how this can affect us clinically. So if we take the brain and we slice it this way, we'll be able to see this view of the brain so that we can understand all of these different signaling pathways that have to accomplish a sensory processing of the vestibular information. So again, this is our inner ear system that we're seeing outside the brain. That information sent through this nerve to now these vestibular nuclei again. But then that information is sent throughout the nervous system. So we see our cerebellar hemispheres here, the cerebellar flocculus and the vermis, which is just behind the brainstem, like we saw in that other view. So that information is sent for processing there, but then it is sent up through the deep parts of the brain, known as the thalami, and then out to the outer parts of the brain, known as the parietal insular vestibular cortex. And these are all different processing stops that help to prune that information and interpret it and then combine it with our other senses for it to make sense. So, one of the most important activities of the vestibular processing is known as vestibulospinal reflex, which is our standing balance control. So let's look at an example of this. So this is a willing participant. I promise. This is a cat, and this cat is demonstrating our postural righting reflex or vestibulospinal reflex, where through gravity sensors, your vestibular system is able to orient your entire spine against gravity to make sure that if you fall, you can catch yourself perfectly. And cats are just incredible examples of this because they have lightning fast reflexes that can adapt so well that they almost never fall without landing on their feet. So it's a beautiful example of the cat is not thinking about this, not micromanaging this. This is reflexive from the vestibular system, helping to right your posture against gravity or against falls. The next function that is classic for vestibular is known as our vestibular ocular reflex, also known as our head-eye coordination. So this connects our vestibular information from the inner ear with our eye muscles, and we can see a schematic here. So what we see here is that with the inner ear information on rotation, for example, that information from the rotation sends signals to the muscles in our eyes, telling our eyes how to move perfectly in response to our head movement in order to keep our vision still. So we can see a video of this to try and understand it. So here is a person who is having their head moved while they are fixating their eyes on a point. And it looks like her eyes aren't moving, but in reality, her eyes are moving perfectly imperceptibly in response to her head movement. So with my head turning to the right, my eyes are moving equal and oppositely to the left in order to maintain that point of vision so that my vision doesn't get blurred and so that I can read things while jogging or I'm able to see, maintain the perspective point when I'm driving because my eyes and ears are perfectly tuned together to maintain that fixation point without it causing a problem. This is kind of a silly example, but this is a wonderful sign of this stabilization that comes from the vestibular system that this chicken is able to maintain its head position perfectly, no matter what the body position is doing, because of these connections through the vestibular ocular reflex and other vestibular reflexes to maintain that precision perfectly, no matter what type of movement they experience. The third function that we think about is known as orientation and self-motion perception. This is a newly discovered function of the vestibular system. Just in the last 10 to 20 years has this become more readily understood in science and recognized in patients suffering from vestibular disorders. So it turns out the vestibular does not just give us a sense of balance and motion perception, it can also give us a sense of how we feel oriented to the world around us, oriented to our internal self, and then also our sense of self motion. So being able to feel yourself move correctly and also feel safe in that movement. And this localizes to the deep brain, the thalamus, as well as its connections to the outer part of the brain, the cortex, the parietal insular vestibular cortex. And this orientation and self motion perception can be really bothersome because if people have challenges in their vestibular disorders, it may be difficult for them to be able to orient, and that might make it difficult to do motion tasks or orientation navigation tasks. And we see that that also applies to the last function of the vestibular system, which is known as spatial memory and multisensory integration. And so this concept is that with vestibular information, our brain is able to help us navigate our world externally and internally. So maybe you've heard of a mind palace where people can store memories or use this as a memory device that if they can physically picture something in their house, for example, they can remember that thing forever. And that's partially due to our vestibular system being able to navigate our thoughts, navigate our circumstances so that we can understand where things are, and that actually helps improve our memory ability. So, the converse of that is if we're not processing vestibular information correctly, it may make it very difficult for you to be able to have that spatial memory and to participate in what's known as multisensory integration, which is this process of taking now disparate pieces of information, like your vestibular information, visual information, and other forms of sensory inputs, and combining that all into one cohesive message that makes sense to you, makes sense to your environment, so that your whole body can feel safe in its environment. So this is an example of someone who's telling you about a trip that they went on, and they can recall exactly, oh, and then we walked over to the Golden Gate Bridge, and we were able to go to this park next door, and then we went to a lovely restaurant afterwards. All of that is related to spatial memory and has roots in that vestibular input. So, what specifically happens when the vestibular system does not work? This is where we can see many different symptoms. So, we'll talk through some of the most common symptoms that are experienced from vestibular system dysfunction. The first symptom that we think of is triggered vertigo. So many people have questions about the term vertigo. What does that mean? From a medical perspective, vertigo is a symptom. It is not a diagnosis. Vertigo technically means any hallucination of movement that you know shouldn't be there. So anything that feels like a motion, that could be spinning, rocking, tilting, swaying, floating, any motion that you can conceive that you know should not be happening counts as vertigo. So it does not have to be a spinning sensation. It does not have to be an internal or an external sensation exquisitely. Any motion perception that you know shouldn't be there. And then there is a subset within vertigo known as triggered vertigo, meaning this is something that you can bring on by doing a specific activity. The most common form of triggered vertigo is when those crystals fall out of place, known as benign paroxysmal positional vertigo. So the crystals that we saw before are located here again in that utricle organ, and we know that crystals are made out of calcium carbonate, or the same material as bone. And so, just like our bones can get weak and over time, and with sometimes trauma, these crystals can also get weak or can sometimes fracture if we've had trauma. And when that happens, you can have tiny little pieces that will break off. And when they break off, they can fall out of place into one of those canals, the semicircular canals. And remember, those are fluid filled tubes. So those crystals can fall slowly down these fluid filled tubes and then can sometimes get stuck in arms that where they're not supposed to be. And so as a result, people will notice when they move their head in the same plane as one of those canals, the crystals will shift. And the crystals will cause that hair cell bundle to deflect, which will send nerve impulses to the brain. So the brain feels like it's spinning, but none of the other senses match that. So your vision information doesn't match that, your touch information doesn't match that, and that is very disturbing to the brain. So people feel usually lots of nausea, vomiting, anxiety because of this horrible sensation not matching, as well as actual vertigo, because that vestibular ocular reflex gets activated, making the eyes start to move as if your head was moving to keep up that VOR fixation point that we talked about, but it doesn't make sense because the crystals aren't supposed to be out of place. So here is an example of someone who has those crystals out of place, BPPV, in their right posterior canal. So let's see if the video is going to play for us. Here we go. So it may look a little bit subtle, but what has happened is this person has laid back with their head down in the right position. And you can see that her eyes are twitching. And if we slow this down to slow motion, you can see this torsional kind of torquing of the eyes. And if you find a blood vessel, that's usually a really easy way to figure out the direction here. And so this patient is experiencing now a sense of rotation as a result of that. And here's another example where you can see even more extreme version. So if we look really closely at the eyes, you see this bouncing twisting, which is known as nystagmus, which is just that vestibular ocular reflex trying to keep up with what it thinks is happening in terms of your head motion. But in reality, the crystals are tricking your vestibular ocular reflex because they have fallen out of place and they're triggering these signals to be sent incorrectly, which makes people very sick. The crystals are made out of the same material as bone, but they're very dense. And so this usually means that the crystals are going to fall down and then settle again within a few seconds. So the classic story someone will say is when I roll over in bed or I tilt my head back, I'll get about 15 seconds of this horrible spinning vertigo that usually goes away then, but I feel really sick or uneasy as a result. And so I try and avoid rolling over in that position or tilting my head in that position. The next common symptom, oops, there we go. So this is a famous golfer who is at a tournament and he suddenly was thrown to the ground. And we'll see a video of this, but you can see right there, he's obviously not feeling very well there. And so if we watch from the beginning again, so here he is, and he's just suddenly thrown to the ground. And there we can see in the distance here, suddenly thrown to the ground there. And so this is a specific type of vertigo known as a drop attack, but it falls into the category of spontaneous vertigo. So what spontaneous means is that you did nothing to bring this on. This attack instead happens completely out of the blue, completely randomly, without you having any warning or any triggering event that you can at least understand. And so in these cases, we think the vestibular system has been irritated or has inflammation that has suddenly started and caused one of these attacks to happen. These are very disturbing, very disabling, and can create a lot of fear and anxiety because patients don't know when this is going to occur. So they become really protective, really fearful of their balance as a result. Spontaneous vertigo can take on any of those motion directions that we talked about. So this is one version with the drop attack, but there can be versions of spinning sensation, rocking, tilting, floating, and there's a wide range in terms of duration. This one lasts just a few seconds, but there can be attacks that can last hours to days that can be recurrent for people. Another classic category that we'll see is our visual symptoms. So sometimes people feel no sense of motion. Instead, they only notice an eye problem. So many of them can end up at the ophthalmologist or the optometrist thinking that they have some type of vision problem that might be the underlying cause. But remember, because of that connection between the inner ear system and the eye muscles, it can really be the inner ear system that is triggering the vision symptoms. And that is very common in vestibular disorders that many people describe vision symptoms, such as the video that we just saw, where you see the spontaneous movement of the world around you. Or sometimes people feel this only when they move their heads. So when they are walking, it's like they have lost their internal gyroscope. So they'll get bouncing, jumping vision only when they're in movement or only when they move their head. So they'll feel like there's a lot of visual lag, a lot of difficulty focusing. They can't read signs when they're walking. They have a lot of difficulty driving because everything feels like it's jumping when the car goes over bumps. So that can be a different type known as oscillopsia compared to the spontaneous vertigo. Because we need that vestibular and ocular reflex intact to have that precision of vision, some people might not have this frank jumping of the vision, but they might just feel like their vision's blurry. They can't really focus on things very well. And that might be related to their vestibular system. And then another consequence that we see, which is very common, known as visual vertigo, is where patients will notice that in complicated visual environments, they can become dizzy or they can get vertigo from just being in the complicated visual environment. This is a little bit complicated in why this happens, but we think because all of us have visual inputs, inner ear inputs, and what's known as our touch sense or proprioception sense for our normal balance. If we miss one of those inputs, like our vestibular system is having a problem, our brain will over rely on the other two inputs, like your visual input and your touch proprioception input. And so we think that it's very common when the vestibular system isn't functioning well for the visual system to be overused and over relied upon. So now complicated environments that previously would have been no problem to tolerate become overwhelming, overstimulating, and really challenging. So it's possible that this is just a consequence of the vestibular system versus a direct result from the vestibular dysfunction. So speaking of that road to balance, and a shout out to Vita, there's some really wonderful infographics, and this one is particularly helpful when considering the balance system. So for the balance system to work properly, we need those three different inputs: proprioception, visual, and vestibular, inner ear. And those different senses give us different balance pieces that are sent to the brain. The brain goes through that complicated processing network that we looked at through the other brain pathways. And then as a result, we're able to get the different components of balance. So we have our sense of equilibrium, our ability to stand upright, those postural reflexes, able to turn our head without falling over, and then having the visually stable environment as well. So as a result, if we have a vestibular problem, we now only have two balance pieces of information to help maintain our sense of balance. So many people with vestibular disorders will notice balance symptoms. They'll say things like unsteadiness, and that could be unsteadiness just with standing or unsteadiness in complicated circumstances like walking or running, or when in more challenging environments like walking in the dark or uneven surfaces, and then having a lot of difficulty with head turns or rotational situations. So many people will say things like, I have to walk with walking sticks, or I have to make sure I have a visual fixation point that I can keep my eyes locked on to feel more steady, or I really am careful about my environment and I avoid trails or uneven surfaces. And I never walk when there's not some extra lighting source because I know that my balance is suffering and I could be at risk for a fall. And this really fits with what we understand from the balance pathophysiology, that if you don't have one of your inputs, you have to rely on the others. So if those are impaired in some way, like your vision's impaired because it's low lighting, or your proprioception's impaired because it's uneven surface, that will make it really challenging for your balance system to function properly. And so you'll notice these balance deficits. We also know that the vestibular system has effects beyond balance, specifically in cognitive effects. So, as we alluded to earlier, in terms of that spatial navigation and sense of um, uh, sensory integration, there can be cognitive consequences without having your vestibular inputs properly processed. So, the three main cognitive aspects that we think are affected by vestibular loss or vestibular dysfunction are spatial memory, executive planning, and navigation. And as a result, many patients who have vestibular disorders will notice what they call brain fog because they can tell that the cognitive aspects of their brain processing aren't working as well as they're supposed to. So many people will say things like they have difficulty with short-term memory, they have word finding difficulty, just can't get that word out, and they feel like their processing is much slower than it's supposed to be. The cognitive symptoms can be really interesting because they can be dependent on the type of vestibular dysfunction that someone has. So, if someone has a vestibular problem that comes and goes, the cognitive dysfunction can also come and go. And we did a nice study where we looked at people who had cognitive symptoms and a vestibular disorder. And we found that if their vestibular disorder was treated, their cognitive symptoms improved or disappeared. So there can be variability in terms of the onset of the cognitive symptoms as well as the permanence of the vestibular of the cognitive symptoms. Um, for people who have a significant loss in their vestibular system, it might make it harder for that to recover because it is clear that the higher order cognitive function needs that vestibular input to really feel grounded and to be able to complete these complicated processes. But this is an emerging area. This is something we're just now learning about in the last 10 years. So we're still every day learning something new in this regard. So now that we've understood the basics of the vestibular system, the common symptoms that can be associated with vestibular disorders, how do we as clinicians go about diagnosing vestibular disorders? So I want to give you the medical perspective so that hopefully you can advocate as well if you think any of these symptoms are part of your challenges. So it's a little bit of a busy slide, but we'll break it down. But from a clinician perspective, our duty and job is to first make sure that there's nothing dangerous going on. So we call this triage, where we want to look for any dangerous causes that could be contributing to your vestibular problems. So we look for any dangerous neurological signs like a stroke. We look for abnormal vital signs. Could the heart rate or the blood pressure be too high? We look for any signs of any type of exposure to toxic substances or traumatic events, anything like that, to first triage and make sure that this is not going to be a life-limiting, dangerous cause to what's going on. The good news with vestibular disorders is it's very rare for there to be a dangerous cause to vestibular disorders. Most of them are quote unquote benign, meaning they will not shorten your lifespan, but they can be still incredibly disabling because of all of these really important functions that they can impair. So, benign by no means is a judgment to how severe the symptoms are or how debilitating they are. It is really just trying to distinguish, is this something that could shorten your life and be dangerous, or is this something that will not cause a shortened lifespan? So once we have triaged a patient, then we want to look into the aspects of the vestibular symptoms themselves. And one of the most critical is timing. So we'll talk about that in more detail. But understanding someone's timing and triggers and doing a focused neurological exam can get you the diagnosis of your vestibular disorder the majority of the time. So it's a really nice part about vestibular medicine is that many of these symptoms can be diagnosed through what's known as a clinical diagnosis. So just meeting a patient, talking to them, doing an exam, you can narrow down the different etiologies of the vestibular disorder quite effectively. You have to know which questions to ask, and you have to know how to narrow that down appropriately in order to do that correctly. But it can be a really valuable tool when done. If we still aren't sure, there are targeted vestibular tests that can be done to more objectively measure the inner ear function and the vestibular brain areas to try and help complement what we think that clinical diagnosis might be. So let's talk about timing in a little bit more detail because this can be really helpful for both you and your clinician in narrowing down what the potential causes are for your dizziness or vestibular problems. So the first step is understanding the onset or pattern of your vestibular symptoms. So do your vestibular symptoms come on acutely? So did this happen just one time? It came on suddenly, within seconds to minutes, and then lingered for a good day or more, and then gradually went away and never happened again. We call that an acute vestibular syndrome. Are these recurrent episodes? So, do you get attacks of vestibular symptoms that happen periodically? you'll feel normal in between, but they can come on either triggered or out of the blue, spontaneous, but there's clearly a recurrent nature to them. That's known as an episodic vestibular syndrome. Or do you have symptoms all the time? Is this chronic, persistent, that never goes away, or is there the majority of the time? So we usually use the number of 50% or more of the time. Do you notice a problem with this? If so, we consider that a chronic vestibular syndrome. So if we can identify the timing, that narrows down our diagnostic possibilities. So for example, in acute vestibular syndrome, we think of two main causes. One is an inner ear infection, which you might hear called a vestibular neuritis or a labyrinthitis if there's hearing involved, or the technical term is an acute unilateral vestibular hypofunction, which just means that one ear is no longer sending signals like it's supposed to. Or do you have a very, very rare manifestation of stroke where you can have a stroke so small that it affects either the brainstem, the cerebellum, or the inner ear itself, causing a loss of blood flow or bleeding into that area that causes dysfunction? That's incredibly, incredibly rare. And it's very rare for that to happen without any other neurological symptoms. So we're usually much more worried about a patient who has other neurological symptoms that come on suddenly out of the blue, as well as vertigo, compared to someone who just has an isolated vertigo that comes on. But those are our top two considerations for someone with an acute vestibular syndrome. Is this an inner ear infection or is this a tiny stroke? For episodic, we want to think about those triggers. So is this positionally triggered? So remember, we have BPPV, where tilting your head back was a classic story that people say will trigger that horrible vertigo. Or are you spontaneous, where these come on without rhyme or reason, out of the blue, and are episodic, recurrent? If positional, the vast majority of them are due to those crystals out of place, known as BPPV. If it's spontaneous, there are two top tier options that we have to think about. The first is vestibular migraine, which is so common. It might be the most common cause of vertigo, period. Now that we're understanding more and more about all the nuances of vestibular migraine, it's kind of a misnomer, vestibular migraine, because most people think of migraine as a headache problem. But vestibular migraine, instead of you getting attacks of headaches, you get attacks of vestibular symptoms. So that could be vertigo, that could be positional vertigo, that could be visually induced dizziness, exquisite motion sensitivity, balance problems, cognitive symptoms. All of those vestibular symptoms that we talked about can come from vestibular migraine and confusingly do not need headache to go along with it. So it can take a really long time to get that diagnosis because many people think that you have to have a migraine headache to be diagnosed. The other spontaneous recurrent episodic vestibular syndrome we need to think about is Meniere's disease. And this is a disease where the inner ear system gets inflamed, either from too much fluid production or inflammatory cells that are irritated. And that will cause attacks of vertigo, but also hearing changes. And that's a really critical point here is that people will say, with my spontaneous vertigo, I will get a horrible fullness in my ear, a loud roaring jet engine noise, and I will have hearing loss. And those symptoms should happen just on one side. And we should see that the hearing loss has been documented loss, meaning that you get a formal hearing test that shows the hearing is gone. Our brain can trick us and can make us feel like we have hearing loss, but the hearing test can be normal. And that's usually a sign of vestibular migraine or another otologic condition that's happening, not a sign of Meniere's disease, typically speaking. Then the last category is chronic, so present the majority of the time. And these are symptoms that are persistent, and the most common cause that we see is persistent postural perceptual dizziness or chronic vestibular migraine, where the episodes have turned now into chronic and consistent symptoms. Now, one of the tricky things about the vestibular disorders is that sometimes people have layers. And so they might have had an acute vestibular syndrome that started this off, but then they developed BPPV after that. And so they'll get punctuated, triggered positional vertigo that can come on after their initial vestibular neuritis. And so sometimes the story can sound really confusing unless you start to think of it in these categories. So when patients come to see me, I will write out, okay, I think you had an acute vestibular syndrome, and then an episodic, and then I think a chronic now that has been left over from you having to deal with these symptoms for so long. So it's really important to understand that these very commonly coexist. And so you might not neatly fit into just one of these categories. And so you have to think about the layering of potential disorders altogether. And then, as we saw in our original schematic, people with cerebellar ataxia can have some brain-mediated problems in their vestibular system, and they might have increased risk of vestibular migraine as a result, or they might have challenge processing that vestibular information, and so just have persistent symptoms like imbalance related to the ataxia affecting their vestibular system, or the double vision or blurred vision from their vestibular cerebellum being affected by the underlying ataxia cause. So something to consider about these layering effects. But if we have a sense of what's going on, typically we can stop there in terms of a clinical diagnosis. But if we still need more information, it's not super clear, that's where vestibular testing can be really helpful. So I've organized this and we'll talk through a few of these, but the general concept is we're trying to objectively measure the individual components of the vestibular system. So from an inner ear perspective, we have targeted tests that can give us information about the individual organs. Remember, there's 5 on each side. And then from a brain perspective, we have tests that can help us understand the processing of that information and how effectively the brain is doing that. So I made a few videos with my office to give a sense of what happens with vestibular testing. So first, the most common is the VNG, video nystagmography. And the VNG is actually a combination test. So it's a pair of infrared goggles that you wear on your head that help us to measure the eye movements. And the eye movements give us a good sense of that brainstem and cerebellum function to see if there's any signs of dysfunction there. And then it also helps us to measure some of that semicircular canal function by doing what's known as calorics, where they blow air in the ear that creates a temperature differential, which activates the vestibular ocular reflex, or that eye ear connection that will purposefully create that jumping eye movement nystagmus, because that lets us know, perfect, that's detecting information like it's supposed to. So this is a combination test that can give us more information about both the ears and the brain. Then our next test that we use very commonly is known as the video head impulse test. So this is a tighter goggle that you wear really, really tight to the eyes because you don't want it to slip at all. And this is looking at that vestibular ocular reflex, or how well are your eyes moving in response to your head movement? And is there any slippage of that, which would mean that the VOR is not working like it's supposed to. So we can test this in all 3 directions of those semicircular canals. So we can do side to side movements, backwards, forwards to make sure that all 6 of those canals are measured to understand if the VOR is working in all of those directions. The next test is called a vestibular evoked myogenic potential. So this is our test to measure those gravity sensors, the utricle and the saccule. So this is a test that we're putting little electrodes around the face because we can, through these electrodes, detect electrical activity in the muscles around the eyes. And that can let us know if those eye muscles are reacting to an inner ear stimulus appropriately. And so for this one, the stimulus is a loud sound. The sound is loud, but not too loud. But it's loud enough that it actually causes those little crystals to vibrate. And when they vibrate, they set off those nerve impulses that then cause the eye muscles to twitch to react to a potential gravity change that's happened. So we can measure that twitch. You can't feel it, but we can measure it to understand, okay, is that pathway from the ear to the eyes working like it's supposed to, or is it having any difficulties there? And so we can measure this for both the ocular and the cervical reflexes. So the ocular reflex corresponds to utricle function, and the cervical corresponds to your saccule function. So both of those are just gravity sensors. Remember, horizontal and vertical planes is why we have the 2. And then another common test that we use is called the rotary chair. And so this is a test looking at low frequency to mid frequency rotation. So semicircular canals can detect any frequency of rotation, just like our hearing organs can hear different frequencies of sounds. Our canals can detect different frequencies of rotation. So that video head impulse test was a very rapid rotation of the head in those different planes. The rotary chair is a very slow rotation. So this helps us to get a full breadth of understanding of the frequency detection. So to do this test, you have the same B&G goggles on, and you're rotated very slowly in the chair at different frequencies, and your eye movements are measured while rotating to see if they are responding accurately to the rotation itself. So these tests can help complement the exam, complement the history to try and help narrow that differential diagnosis, as well as decide if there are layers that maybe are working together to cause a constellation of vestibular symptoms. Well, then I wanted to briefly go over some treatment options before we open for questions. So as you can imagine, specific vestibular disorders may have different treatments, but there are some general ones that can work really well. So first is a clear diagnosis and education. I can't overemphasize this. Having a sense of what your diagnosis is not only important for determining your treatment plan, but it is really important for the psychological aspects of vestibular disorders. Vestibular disorders are disabling, they're invisible, they're underdiagnosed, and they're sometimes dismissed in the medical community. So having a clear diagnosis and understanding of what's going on can really help first you process that information. It can also help your stress response system interpret information more accurately. Because by definition, vestibular disorders are triggering to our fight or flight reflex. And so many people can get anxiety and depression. And so if we can give our brain a sense of you're safe, we understand what's going on, now we need to adapt and heal, that can be a treatment and therapy by itself. Lifestyle is a big deal for vestibular disorders. So, if our brain doesn't have its full bandwidth to function and to adapt, it's much harder for us to heal from or adapt to vestibular disorders. So, we use a mnemonic called SEATS: sleep, eating, exercise, drink water, and stress management. These are kind of well-known, understood basic things, but it really is critical, especially sleep and stress management, for that to be part of your treatment plan to ensure that your brain has the best optimal health to improve. Psychological support because of the increased anxiety and depression from vestibular disorders. Many people can benefit from having psychological support. That's different for everyone. That could be exercise, that could be talk therapy, that could be mindfulness meditation, but it is a really challenging thing to go through. So having some extra support there can make a big difference. And then physical therapy. Movement is medicine. Many people reflexively stop moving when they have vestibular problems because either they trigger vertigo or they're worried that they're going to fall and hurt themselves balance wise. And in reality, it is the opposite. We need movement to help retrain the brain, retrain those vestibular reflexes to adapt and improve and compensate. So, exercise is incredibly important. If that's too hard or challenging, physical therapy can be the bridge. So it can help us to work on compensation for an inner ear weakness. It can improve our overall balance management and balance compensation by using those inputs like our visual and proprioceptive, and they can treat those crystals out of place. So there's specific mechanical maneuvers that we can do to treat that. Many people also tighten up their neck and shoulder and back muscles when they're dizzy. So many people can notice more cervical problems, neck pain, neck headaches. So sometimes complementing this with orthopedic neck physical therapy can be really helpful. Quick 2 cents on the mechanical maneuvers for BPPV. This is a mechanical problem. So you really have to do exercises to put those crystals back in place. Medications are not going to help that. So either you can do that on your own, which has a pretty good success rate, or you can get a physical therapist to help you out. And then finally, medications. There can be medications that are helpful for vestibular disorders, but these should be targeted to the etiology of your vestibular problem. So I just listed some common ones here, with vestibular migraine being the most common, and vitamins and migraine medications can be helpful. Meniere's disease, we're usually working on different types of water pills to try and help decrease any fluid pressure in the ear. Interestingly, internationally, there are a lot more vestibular specific medications than we have available in the US, like Stannerosine, flunarizine, and beta histine. So if any of you live outside the US, you've got a few extra options than we do. And then from a vestibulocerebellar perspective, the 4-aminopyridines are very helpful in stabilizing the firing of our cerebellar cells. And so if we can stabilize that firing and improve the efficiency of the signaling in the cells, that can help improve the vestibulocerebellum, which can help to improve a lot of those symptoms for people. So that could be things like actual vertigo sensation, balance problems, blurred vision, downbeat nystagmus, but it is very rare to find cerebellar disorders that respond to this medicine. So not every cerebellar ataxia will respond to this medicine, but it's always good to have that on your radar to ask your doctor if this would be something for you to try because it can be really helpful for certain people. And then last plug for exercise, specific vestibular exercise is very helpful, but aerobic exercise in particular might be specifically engaging for what's known as neuroplasticity. So more and more studies are showing how we need as much aerobic exercise and intensity with our cardio training to really engage that brain responsiveness. So with that, I will leave us some time for questions. And I want to make sure that you all know about vestibular.org. And I think we're going to put that in the chat. So if you have more questions or want to look for some really good information, please go to this website.
Thank you so much, Dr. Steenerson. We're going to move into our Q&A period. Let's dive right into questions. So first, we have a question from an attendee who asked, does age or aging impact the vestibular system?
Yeah, great question. So, as you may know, our hearing can decline over time, and we think that the vestibular system follows a very similar pattern. So, we see specific vestibular decline, where just wear and tear over time will cause those cells to age and not function as properly. But then our other balance inputs can also age. So, our vision can age and our joint position sense can age. And so, there can be a cumulative worsening of balance as a result.
Good to know. Our next question comes from an attendee who wants to just clarify something that was shared in the presentation. Can there be vision issues connected to the vestibular system that have nothing to do with nystagmus?
Oh, yes, definitely. So if there is a vestibular loss, that means that you're no longer getting that communication between the eye and the ear movements. And that does not generate a nystagmus. A nystagmus is usually generated by an irritation of that vestibular ocular reflex.
Thanks for that clarification. We have another attendee who asks, can you provide a definition of a migraine? I'm trying to understand how vestibular systems can be classified as a migraine.
Yeah, wonderful question. And migraine is a evolving definition. So from a classic neurology perspective, a migraine headache is a severe headache that causes you to have sensitivity to lights or sounds or smells that worsens with physical activity, is typically throbbing and on one side of the head. And that gets better with rest or sleep or migraine medicines. But what we're learning in neuroscience is that migraine is much more than a headache. Instead, migraine is likely a hypersensitivity problem where the brain's ability to filter information is not working as well as it's supposed to. So the brain can get overwhelmed, overstimulated, and therefore feel more sensitive to lights that don't bother other people, or sounds that don't bother other people, or smells that don't bother other people. And motion is one of those senses. So people can become exquisitely motion sensitive, head motion, eye motion, visual motion can now become really disabling or disturbing. And then we think that once you're past your breaking point, overwhelmed, brain's no longer functioning, then you'll have an attack, or essentially one of those sensory systems goes haywire and you'll get a manifestation of a migraine attack. So if the touch pain system goes haywire, you get a migraine headache. But if the vestibular system goes haywire, then you get a horrible vestibular symptom, usually lasting minutes to days at a time, and is reversible completely.
Thanks for explaining that. Our next attendee who is interested in how people who have vestibular challenges as a baseline, how those vestibular challenges might get worse if they have a cold or a flu or something like that. Is anything known about those kinds of complications?
Yeah, that's a wonderful question. So this is a common challenge in anyone with any neurological problem is that we understand that when we have a neurological problem, the brain will do its best to adapt and compensate. But those are new pathways that have been created. Essentially, the brain does to try and help create this compensation. But those new pathways are also the most vulnerable if our brain is stressed by other things happening. So those stressors could be physical, like illness, dehydration, exhaustion, too much sun exposure for some people, exercising too hard. It can sometimes be emotional or psychological, too much stress, not being able to have coping mechanisms that are helpful for you. All of those can overwhelm the brain. And so the brain will default back to that original pathway, meaning that you will get an amplification of whatever that original nervous system injury was. We'll sometimes call it a recrudescent syndrome.
Well, that's good to know. Next, we have a question from an attendee who has a genetic form of cerebellar ataxia, but also has recently been diagnosed. They have a meningioma on the on their balance nerve near her left ear. She's interested if these two things, what might be impacting her balance more?
Yeah, it's a really good question. And that is an area where the vestibular function testing can be super helpful because that can quantitatively measure how much the inner ear system's involved, if at all. Sometimes people have those meningiomas and they're just next door neighbors. They're not actually causing any problems. It's a red herring. You don't have to worry about it. Others, the tumor is connecting with the inner ear system, and that can impair the function. So vestibular function testing can be really helpful to understand how much this might be related. And it's really important to stay exercising. That is such an important way to try and deal with any evolving thing like a potential tumor by the balance nerve.
So helpful for vestibular symptoms, very helpful for cerebellar symptoms.
Yep.
Exercise is great.
Yep.
We have a clarification question speaking about different ways you can compensate or help cope with symptoms. We have an attendee who asks, what kinds of vestibular symptoms does vestibular therapy help improve? Would it help improve visual symptoms such as nystagmus or double vision?
Yes, great question. So it does depend somewhat on the underlying cause of the vestibular disorders. Vestibular therapy can help anyone with coping. So it's very helpful for what we call desensitization and habituation. So just helping your brain get used to the symptoms, make it less scary, figure out ways to maneuver those symptoms. They can help anyone with that. It's very helpful in terms of taking away symptoms for benign paroxysmal positional vertigo, BPPV, so helping to mechanically put those crystals back in place, very effective. It can be helpful if someone has an inner ear infection where they suddenly have a weakness that happens on one side. They can accelerate the healing by giving you targeted exercises to teach your brain how to compensate more quickly in that regard. And then vestibular therapy is exquisitely helpful for fall prevention. So there's a really landmark study that showed over a 90% reduction in falls in people who complete vestibular therapy. And interestingly, you didn't have to have a vestibular disorder. So is it because it's engaging the vestibular system more? Is it helping you to understand your balance inputs and weaknesses and compensate for those? I don't know the answer to those questions, but it's very effective.
Well, that's fascinating. Thank you so much, Dr. Steenerson. Our last question today is actually for you, Cynthia. We've had a number of people ask, where can they go to learn more? Are there different events coming up focusing on vestibular disorders? Could you speak a little bit about the different resources offered by your organization specifically for vestibular symptom support?
Absolutely. So the Vestibular Disorders Association, or VIDA, has a website, vestibular.org, and there are over 130 peer-reviewed articles on there about the vestibular system, about vestibular disorders, about coping strategies, and connecting you with support groups. So I highly recommend you check out our website. There's also an easy-to-use new patient toolkit that can lead you through the website and where to go to get the information you need. We have a lot of videos on our YouTube channel as well, including webinars like this. And we have an annual virtual conference, which is this year is coming up March 2nd through the 6th, 2026. We also, we've been having this is our 6th year. So we have previous conferences that people can watch each day. There's a 1 hour an expert speaker followed by a patient panel on the same topic. So I think there are a lot of topics that people here might be interested in coming up at this year's conference, including an in-depth talk about vestibular rehabilitation therapy and neuroplasticity, as well as Dr. Steenerson and Dr. Shin Bei, who's a vestibular migraine expert, are going to be talking about when conditions overlap, both vestibular conditions, when you can have both vestibular migraine and triple PD, for example, and when you can have a vestibular problem as well as a non-vestibular problem and how they overlap and what the impacts of those. So highly recommend checking that out. You can find that on our website or go to vestibular.org/LRL for Life for Balance Live.
Thank you so much, Cynthia. We weren't able to get to all the questions today, but if you do have questions remaining, please feel free to reach out to us at research@ataxia.org. We're happy to send them to the right places to get you some answers. And if you need help, sometimes it can be difficult distinguishing what is a cerebellar symptom, what is a vestibular system, what if it's both. We can also help you out in that sense as well. But with that, Dr. Steenerson, Cynthia, thank you so much for joining us today. We really appreciate your time and expertise.
Thanks for having us.
Thank you so much.
And for everyone here who spent the last hour with us learning more about the vestibular system, I hope you learned something new. And wherever you are in the world, good morning, good afternoon, good evening. Have a wonderful rest of your day. Take care and stay safe, folks.